All attendees are in listen-only mode.
Good evening, this is Dr. McSherry and Dr. Farnham, guest faculty tonight. It is December 2nd, 2013 at 9:04 p.m. Tonight we're going to be going over case of the day number 15, which is an office topic. And Dr. Joanne Floyan is supposed to be one of our candidates tonight. Unfortunately, she is not here. So Dr. Mina, I'm going to go ahead and put you on. I told you could possibly go, so I'm going to take you off of mute. Hi, Dr. Mina, are you present?
Hi.
Hi.
Hello.
See, I was able to
Yes.
get you in. Remember I said?
Can you hear me?
Yeah, I can hear you fine. Can you hear me okay?
Yeah. Can you hear me?
Yes, I can
Okay.
hear you fine.
Yes,
Yeah.
thank you.
Yeah, we can hear you. Okay, Dr. Mina, I'm going to have you do the case of the day, okay? Dr. Mina?
Okay.
Okay, you're going to do the case of the day, okay?
Yes, I'm here.
Okay. All right, Dr. Farnham,
Yes.
you can go ahead and take over. Let me give you the mouse.
Okay.
And you can just click on the screen to change the slides. They should be all on a delay, okay?
There we go.
There you go. Just click on right on the screen. There you go. Okay, you got
Okay.
it.
Your exam is this week? Hello?
Dr. Mina?
Hello.
Yeah.
Yeah, can you hear me?
Oh, it's in January.
Oh, January. Oh, okay, so you're good. All right, so we're going to do the case of the day. So it's the 63-year-old GTP2 presented for some reason, ended up getting a bone scan, and you have a T-score of 2.3. What does this mean?
This is osteopenia. Oh, no, I'm sorry. This is osteoporosis minus 2.5 multiples of median.
So give me two different opinions. So what is this? What does this
This
mean?
is less than 2.5 multiples of median, so the patient has osteoporosis.
Osteoporosis. Okay, so why don't you tell me what you think the different categories are as far as trying to stratify what the patient's bone mass is according to T-scoring.
Okay, so T-score of my less than 1 point, wait, I'm sorry, I'm confused now. Less than 2.5 multiples of median is osteoporosis, minus 1 to 2.5 is osteopenia, and less than 1 is normal, or more or above. It's within normal limits.
Okay, so according to the classification that you just gave me, she would have what?
She is osteopenia. Is that
Okay.
right? Yeah.
Are you sure? All right, because that's the fourth time you've changed your mind. Okay.
Yeah.
So the term for this is now low bone mass. They've kind of done away with the term osteopenia. So yeah, more negative, because instead of less than or more than, because it's confusing because you're dealing in negative numbers, you'll say less negative than -1 is normal, or any positive number. More negative, or -1 to -2.5 is low bone mass, and more negative -2.5 is osteoporosis. Okay, so when we're reading this,
Okay.
they say that they've given you a T-score. So what does that mean? What does a T-score mean? What does a Z-score mean?
T-score is the standard deviation from the peak of compared to the young adult bone mass
And how do you distinguish that from the
versus the Z-score is the standard deviation compared with sex, age, and race.
Okay. So which one do we use as far as evaluating whether or not they can get a treatment? Do we use the one that's
It's the T,
the T-score? Okay.
the T
Okay.
scoring.
All right. So now there's this new thing that they call the FRAX. What is that?
FRAX is to assess, also called fracture risk. It assesses the 10-year risk of a patient in developing fractures within the next 10 years. We can assess this by, it has a criteria. like presence of fracture, rheumatoid arthritis, age, what's the sex, and then it adds up, and then it determines your fracture risk within the next 10 years, and common of used if you're more than what, 60, 65 years old, or if you have any risk factors.
Okay, so when would we start screening people for osteoporosis? What age?
Age 65 or less than 60 if you have any history of risk or history of fractures, Caucasian race, low bone mass, history of glucocorticoids, immunosuppressed states, or low BMI, spontaneous fractures, or use of steroids.
Okay, and so the clinical risk factors that are used in the FRAX, you mentioned age, sex. What else were the risk factors that go into calculation?
F for presence of fractures in the past, rheumatoid arthritis, age, sex, alcohol use, what else? Steroids.
Okay.
And smoking.
Yep. Social history or family history, parental hip fracture. Okay. So when do we use that?
If you have osteopenia, like T-score of greater than -1.
Okay, so what is osteopenia again? What is the range?
Osteopenia is -1 to 2.5, or low bone mass. That's what I said.
Yeah. So postmenopausal osteopenia.
Postmenopausal women, okay, patients with a T-score indicating low bone mass, -1 to 2.5.
Yeah, if they're osteoporotic, you got to initiate treatment. So this is really for someone, we don't know. I mean, do we initiate treatment for someone with low bone mass? And so this is a tool to, it's kind of like the HPV for ASCUS. I mean, it's like, do we COPO, do we not? So do we start treatment therapy for low bone mass or do we not? This gives us more information. All right, what FRAX score would you initiate treatment? So now we have the information. So
I don't know.
A sufficient score that would indicate that you need to start a treatment?
I thought that's computer generated.
Yeah, it is. But
if you have a
so I mean, what is your risk of a hip fracture?
Oh, there's a number?
Well, right, because that's what
I thought it adds up on that computer thing. Oh.
Right, but understand.
When they initiate, if you have
yeah, and so it spits out a thing and it says start therapy or don't therapy. But the point is that it's a 10-year calculated risk of hip fractures and hip fractures and or major osteoporotic fractures. So if your risk of a hip fracture is 90%, do you think you start therapy? Yeah, of course you'd start therapy. So what's the threshold? So 3%. 3% risk of a hip fracture or 20% risk of a major osteoporotic fracture or both in the next 10 years, and that's the cutoff for which you would decide to start therapy for low bone mass, as opposed to, osteoporosis, at which time you would just start therapy.
Okay.
There we go. How would you manage a 66-year-old with this? So there's another clinical. So different patient now, 66-year-old with a T-score of -2.6. What are you going to do?
So she is -1 to 2.5. She is considered osteoporosis. So I'll start her on treatment with either bisphosphonates, such as alendronate, risedronate, depending on her medical comorbidities.
Okay. So,
and then work her up, of course.
Okay, so exactly. So before you go throwing therapies around, what is your workup? What do you want to do?
I'm going to do a CBC, chemistry, TSH, get a urinary calcium level, hydroxyvitamin D, PTH, determine for other causes of secondary like hyperparathyroidism.
Exactly.
Or
So
low bone
you want
mass.
to make sure there's not, cancer, alcohol abuse, hyperparathyroidism. So you're going to check the labs. You're going to get the social history, family history, everything that could potentially be related to that. Now, for every patient, you're going to recommend postmenopausal women, calcium, vitamin D supplementation, weight-bearing exercise, and cessation of smoking. You're going to recommend that to everybody in falls prevention. So what is currently recommended then for calcium and vitamin D supplementation?
For older women, 1200 milligram and 800 for vitamin D international units.
Okay. Yeah, exactly. Now we can get to treatment. So what is your drug of choice?
I would start with bisphosphonates and like 70 milligram every week. If she can tolerate this, I would counsel her very well regarding possible symptoms of esophagitis, not to stand or sit upright after taking the medications. And if she can tolerate this, then I would keep her on that medication.
Okay. What other? Well, so you're going to say that your first line therapy is biphosphonate. Why would you choose that drug? Assuming there's no contraindications, which we will get into in a minute, why would you choose that drug as opposed to some other drug?
Once a week, the once a week bisphosphonates is easier. It will be easier to remember. But if she's like in a nursing home or she's got multiple comorbidities, then I would give the IV, like reclassed,
Sure, but
which is once a year.
Is there anything?
It'd be easier for her.
Is there anything particularly about biphosphonates that makes them a better option than some other osteoporosis therapies?
Mainly for hip and spine reduction of fractures, mainly.
Exactly. So they have both hip and spine. They have data that demonstrates a reduction of fractures at both the hip or vertebral and non-vertebral or hip and spine for each of the biphosphonates. Some of the studies were done differently, but basically all the biphosphonates have some data that relates to vertebral and non-vertebral. Not all the drugs have that, and that's why it's a good first-line agent. Now, what other? Well, I'm going to skip ahead to the next one. But what are the contraindications of? Hold on, I think that's on this slide actually. Let me. Oops. Okay, contraindications. What are the contraindications?
Esophagitis, hypersensitivity to the medication, hypocalcemia. If the patient has any reflux issues.
Okay, renal insufficiency as well. Okay, good.
Renal insufficiency.
Now, what other drug could you? Let's say that she had, she has H. pylori or something. What else could you use?
The IV form, which is like the reclast, which inhibits osteoclastic activity. That's the IV infusion. I can also use how do you call that? Denosumab and salmon calcitonin and the parathyroid hormone recombinant.
Okay. So what?
How do you monitor the patient?
There's probably two other therapies. Well, yeah, and I moved ahead on that one, but we'll come back to that in a minute. What are the?
Okay.
I don't know how to back this up.
Others.
Well,
SERMs.
I guess we can. We'll
Did you want me to back it up?
one thing. Okay, perfect. Yeah. We'll back it up and then we'll go on that one in
Okay.
a second. All right. So yeah. So CERM. Okay.
So we can use SERMs, salmon
Yeah.
calcitonin, recombinant parathyroid hormone,
One.
denosumab, and the IV class as other
Why is it?
alternatives. Hello?
Doing that?
Hello?
Oh, it went back.
What do you want to move? Do you want to move ahead or do you want to go ahead?
I want to move ahead, but can you hear me?
Yeah, I know you're kind of going in and out a little bit.
Okay. All right. All right. Can you hear me now?
Yeah, perfect. Okay, go ahead.
Okay. I can. If it keeps doing that, I can call in, I guess.
Yeah, I'll let you know, Rick. I'll send you a text message if it is. Okay.
Okay. All right. So what's the other therapy that you can use?
SERMs?
Yeah. No. The one that you didn't already mention.
I said earlier, reclass, denosumab, calcitonin, recombinant parathyroid hormone, or SERMs,
Okay.
such as raloxifene.
You're just not going to tell me. All right. That's fine. How does what kind of fracture data does the calcitonin have? Hip or spine?
What kind of, I'm sorry, say it again, what kind of,
What fracture data
it
does
reduces vertebral fracture?
calcitonin?
Yeah?
How is that administered?
It inhibits osteoclastic activity, therefore it reduces vertebral fractures and associated bone pain.
How is it administered?
I think that's the spray, right?
Yeah, it's intranasal.
On the nostril.
It doesn't have
Something.
definitive. Yeah.
No, salmon something.
Yeah. So it's intranasal, and it does not have definitive fracture data for hip or spine. What about the selective receptor, estrogen receptor modulators? What fracture data do those have? Where do they prevent fractures?
It also it lowers the rate also of vertebral, same as the calcitonin, but not the hip fractures. It also inhibits osteoclastic activity.
Right. Is there anything that stimulates osteoblastic activity?
Stimulates osteoblast. Let me see. The parathyroid hormone recombinant, right?
PTH is the only one.
The RPTH.
That affects osteoblasts.
That has osteoblastic activity. Yeah, that's it.
Okay. And what is the denosumab? What is that?
It's it's an antibody that binds to the rank ligands. Therefore, it inhibits the osteoclastic activity also.
Yep. Okay. Good. All right. Let's go here. All right. Oh, Jesus. All right. How do you monitor the patient for response?
How do you monitor? Follow them up a month later and determine how they responded to your treatment, and then
what do you mean?
I guess repeat the DEXA scan in about 2 years. Okay. If they have any side effects from the medication, any problems, any adverse effect, any complaints at all, and then repeat the DEXA scan around 2 years to determine if they're worsening, improving, or stable.
Okay, so what if they come back and their DEXA scan is no better than it was when you started it 2 years ago? What are you going to do then?
Continue treatment and counseling.
Okay. Yeah. So basically, you have them come back. If it's not worse, then you can keep the same therapy. You do want to just make sure that they're being compliant with therapy.
Same
You can check
therapy,
and see
okay.
if they've refilled it, with the pharmacy if they're actually taking the drug. If not, and compliance
Follow
is
up
an
in 2
issue,
years.
what else could you do? What could you do if compliance is an issue? What if they're
I'm
not
sorry, what did you say?
what could you
What
do if compliance
approach?
is an issue?
What if they're not taking it? What if they're not taking it, is your question?
What would you do?
Counsel them about the adverse effect of fractures and its comorbidity.
Yeah, that's awesome. So what are you going to do about their therapy?
Talk to them and find out what the problem is first, what's causing them not to take their medications, and then find out some other alternatives that would be easier for them in order
So
for them to be more compliant.
in this scenario, you repeat it in 2 years and it's worse. So one of two things happening: either the drug isn't working or they're not taking the drug. So we need to find out if they're not taking it. If they're not taking it, then what can we do?
I guess involve the family if they're elderly, is to make them more compliant. Or if they're in a nursing home, then notify whoever's their guardian or whoever's taking care of them, and follow them up more closely, like intensive, careful monitoring.
Okay, so you see them back in 2 more years, and now it's negative 3.5. Do you have any other bright
Oh
ideas?
gosh.
Anything else you want to do?
Recombinant parathyroid hormone.
Yeah, you could, but the answer is give them something that they can be compliant on, right? And you already said that earlier, so you don't have to try to think through that. You don't have to try to read my mind. Just answer the question. So I mean, if they're not taking it, then give them once a year. You know what I mean? Just do another drug that does the same thing, but for which compliance is better. Do you see what I'm saying? So, or if it does get worse, then yeah, of course, if it gets worse and they are taking it, then you would consider doing the PTH or something like that. And of course, you're going to still evaluate for secondary, causes of, of possible failure. How often should you repeat the DEXA monitoring?
Every 2 years.
Yeah, every 2 years. That's osteoporosis. If it's osteopenia or low bone mass, and the FRAX does not have you treating it, then you can repeat it up to 10 years. It kind of depends on compliance. So what's the role? And so this is the one that you wouldn't tell me. What's the role of hormonal therapy? Right? That's the only one you didn't mention. Okay.
So it's approved for the prevention of osteoporosis.
Yeah. Oops.
Okay. In Williams.
Okay. Good job.
Okay, next candidate up.
Okay, thank you.
No problem. Is going to be Dr. Hood, and let me go ahead and get rid of this. And thank you, Dr. Mina, for coming in at last minute.
Thank you.
No problem. Okay, Dr. Hood, let me go ahead and pull your name up here, and I'll get your case list up. Make sure you are available by microphone. Dr. Hood, are you present?
Yes, I am.
Oh, wonderful. Excellent. Okay, and let me just pull your case list up. Just give me a second here. And
Actually, I had my case list modified, the one that I sent to ACOG, so I inadvertently sent you the unmodified version.
okay, this is the one that you sent me, most recent.
Yeah.
Is that okay?
Yeah, sure, it's the unmodified version, but the point is pretty the same. The cases are
Okay.
the same.
All right, let me just go ahead and cancel. Oh, come on. Just give me a second here. For some reason, this program sometimes gives me a little bit of a problem. I just had to flip it. Okay, Rick, I think you can go ahead and scroll around if you want to find something that, go ahead, Rick, you can go ahead and
Sure, sure.
whatever you like.
What do you want to do? OB/GYN or
OB?
want to do OB? Okay. Let's take a look. All right, go ahead and tell me about number 15.
15. The 27-year-old GAP7.
Yeah, that one.
Okay, patient 15 was a 28-year-old GAP7 presented with actually good prenatal care, but presented at 33 weeks with preterm premature rupture of membranes.
Yeah, present the case.
So patient presented again at 33 weeks with preterm pre-rupture of membranes. She was monitored. There was continuous feeding monitoring. We knew her gestational age because she had an early second trimester ultrasound. So with her gestational age, I started prophylactic antibiotics for GBS prophylaxis. She got a dose of IM steroids. We used betamethasone, and we also, and she was not tocalized at this point. There was also an MFM consult. Patient delivered vaginally, spontaneously, approximately 24 hours after, within 24 hours of her admission.
Okay, and looks like the baby did pretty well. Now, okay, so what are risk factors for PROM?
Risk factors for PROM. There's any vaginal infection, a history of pre-PROM. I'll start with that. History of if there's any current vaginal infection, if there's any trauma, if there's any, I would say illicit drug abuse, scant prenatal care or no prenatal care, incorrect presentation, multiple gestations, fetal anomalies, history of shortened cervix.
Some of those are risk factors for preterm labor, but not for preterm PROM. What, okay, how about cigarette smoking? Is that a risk factor?
Yes.
All right. How much does that increase the risk? Like 100,000 times or 5 times, or how much does that increase the risk?
I'm not exactly sure. I would surmise a small percentage. I would maybe give within 5%.
Okay, it actually 200 to 400%. It increases it 2 to 4 times higher if you're
4 times higher.
Okay. Cigarette smoker. What? How do you know? So someone comes in, they say I'm leaking. How do you determine if they're leaking or not?
I do a sterile speculum exam. If they're so sterile speculum exam, I check for dilatation. I check for pooling. I also have the patient Valsalva or cough during the speculum exam. Whatever fluid that I retrieve, I go into a slide prep, and I'm looking for ferning. I also have litmus paper, and I'm looking at an increased pH. And sometimes if at that point, if the things are still inconclusive, I'll do an ultrasound for a current AFI.
I see. Now, Go ahead.
It also have the patient walk. I put a pad on the patient and have her to walk labor and delivery for approximately an hour, and I can reevaluate her if it's still inconclusive.
I see. Now, you say you use some kind of litmus paper. What are you looking for? What would that tell you?
I'm looking for increased alkalinity. So a pH of approximately 4.5 or greater.
Okay. What's the normal vaginal pH?
About 4.
4. Okay. And so 4.5 would be consistent with rupture?
It would be consistent with rupture. I wouldn't diagnose it on that solitary finding.
I see. Okay. So what else can you do? Is there any other thing that you can do to check to see if this is in fact amniotic fluid?
Pooling, ferning, litmus paper, AFI, outpatient bulk. That's what I would usually do.
Okay, what is an amnisure? What does that look for?
In amnisure, quite honestly, I'm not familiar with an amnisure.
You don't know what that is?
I never used it.
Okay, is there any advantage to using that? Does it, are there any other, the tests that you had previously mentioned can have false positives, so does this test have any benefit with regard to those things or no?
Amnisure, from what the name indicates, it seems as if it would have a higher specificity in not just sensitivity, but higher specificity, which could exclude things like urine or blood or semen or other contaminants that could be present in the vagina.
I see. Okay, so you said higher specificity. So what do you mean? How high of a specificity does this have?
I honestly never heard of it. So I can take a shot at it and say the specificity for amnisure would greater than 90%. If it's a new mechanism that they're using for increased specificity, I would imagine it would be at least 90% or greater.
I see. Okay. What about fetal fibronectin? What does that look for? Or how does that work?
Fetal fibronectin is actually assessing the likelihood of the onset of labor within the next 24 to 48 hours.
Can you use it in this setting to determine if they're ruptured or not?
I've never used it in this setting. I don't know it being approved for to qualify a rupture or not.
I see. Okay. So I'm going to go over a couple things just from the confirmation of rupture stuff that we talked about. So,
Sure.
well, before I do that, is there any other test that you could do to evaluate whether they're ruptured? Let's say that it's still inconclusive. You know, you really want to know whether or not this could be a rupture. It's going to alter your management. Anything else that you could do?
Can't think of anything else at the moment, but I have a suspicion there's something else you can do.
Okay. So let me go over some of the things that you mentioned. So, and you're going to get yourself into trouble when you're just guessing. Like, and most people just guess. You broadcasted the fact that you have no idea what you're talking about and you're guessing. So I definitely wouldn't do that. If you don't know, just say you don't know, and that's fine. If you are going to guess, just guess. Don't say that you're guessing. So the nitrazine test looks for an alkaline pH. What would an alkaline pH be?
Greater than 4.5, 4.5 or greater.
Really? You took chemistry in college? So 7 is a neutral pH. 7 basically means there's no acidity and there's no alkalinity. Okay? Anything less than 7 is acidic. Okay? So the normal vaginal pH is 3.8 to 4.2. Okay, that's very acidic. It's a logarithmic scale. As you go down from 7, it logarithmically increases in acidity. So 4.5 is very acidic. It's just less acidic than 3.8 to 4.2. Okay?
Sure.
So 7 would be no acidity and no alkalinity. Amniotic fluid is somewhere between 7 and 8. Okay, so it's actually very, well, it's not very alkaline, it's alkaline. If you do a pH paper and it comes back 4.5, that means you have BV. It's not, that is not at all suggestive of ruptured membranes, okay? With nitrazine paper, that's a different pH scale. So a pH paper will go from like 3 to 6, okay? And it'll change colors if it's slightly less acidic than a vaginal pH. A nitrazine paper is actually a broader scale. It turns blue when it's actually alkaline. It turns blue above 7. So when you're doing these tests, it's important that you have some idea of what the changes correlate to as far as the actual pH scale. The other things are fine. You can look for, coughing. You can look for leaking of fluid. You can look for the arborization or the ferning under the microscope slide. And then we didn't specifically talk about false positives and negatives, but what can cause a false negative, or I'm sorry, false positive when it comes to pH testing?
In the presence of semen, in the presence of other vaginal infections,
No.
such as
No, we just talked about that. That's
or
not going to
semen.
give you an alkaline pH. That's not going to give you a false positive. That's not going to turn nitrazine positive. So blood, semen, or if they had soap, those things could actually cause a pH above 7, okay, which is the thing that would turn, that was what would turn nitrazine paper blue, okay? What about ferning? Anything that causes a false positive ferning?
False positive ferning.
Cervical mucus. If you have cervical mucus, that could cause
Mucus.
ferning. Okay. Now, the other test that we talked about, the Amnisure is a test for placental alpha microglobin 1, microglobulin 1 rather, and it is fairly sensitive and specific. I don't know that you have to know the numbers, and you were actually pretty darn close when you guessed. So if you're going to guess, just guess. Don't say that you're guessing. So the specificity was 87.5 to 100%. Sensitivity is 95 to 100, well, 95 to 98%. So it's actually pretty good. It's pretty sensitive and it's pretty specific. It should be used after those basic tests are equivocal, though, because it's kind of expensive in comparison to just doing those basic tests. There has been some study or research that looked at fecal fibronectin. So in intact membranes, a negative fetal fibronectin result strongly supports the absence of ruptured membranes. So it could be used in that setting. And the only other one test that we didn't go over that you could be used, it'd have to be kind of dire circumstances, I would think, when it's really going to be important as far as how it's going to alter your management, is an indigo tap, right? You can do an amniocentesis. You could actually instill indigo carbon into the amnion and then give them a tampon and have them walk around. And if it turns blue, then obviously they've ruptured. That's been described. I don't know how often that actually gets used, but certainly that's a possibility. That's something you can do. Okay, now, as far as this patient coming in with ruptured membranes, you said you'd given her GBS antibiotics. Would you not give her PROM antibiotics?
Yes.
Okay, what's the difference, or is there no difference?
With GBS prophylaxis, I would typically use ampicillin or penicillin, or Clenda for any allergies.
Okay. So is that the same as PROM antibiotics, or those are two different things?
And no, it's not the same for
No, it's
PROM.
not. Okay. So the 2008 meta-analysis of all PROM antibiotics, and what was the antibiotics that they had to check? Because there's been literally dozens of different regimens. What was the one that seemed to be the most effective?
The erythritol, the AMP and erythritol.
Sure. Yeah. Okay. So when you presented, you said you gave her GBS antibiotics. Why would you do that? Why wouldn't you give her AMP and erythritol? Why wouldn't you give her the PROM antibiotics?
In retrospect, it could have been I didn't delineate on here, and I wasn't thinking clearly.
Okay, so if you're gonna, is your test this week?
Yes.
Okay, so you would, if you were asked this question this week, you would say that you gave PROM antibiotics?
Yes.
Oh, okay, I'm just checking. I didn't know if there was some reasoning behind that, but I would. I mean, so it seems like that would be the thing to do. Okay, so you also gave her steroids. You gave her, what did you give her?
Betamethasone.
Okay, why did you give her that? What if your nurse said, we don't have any betamethasone, we have hydrocortisone. Can we give hydrocortisone?
Yes, you could.
That's a steroid. We'll just give some of that. Give her 100 milligrams of hydrocortisone.
I wouldn't know the dosing. I don't know the dosing.
You don't know the dosing, but that would work as well? What do steroids do? Why do we even give steroids? What's the point?
You're trying to hasten the fetal lung maturity.
I see. Okay, so what are there are many, but what are the 4 major morbidities of prematurity?
Necrotizing and Tocolysis, intraventricular hemorrhage, ARDS.
Well, not ARDS, that would be adult.
I'm sorry, respiratory.
Okay. And what else?
In hyperbilirubinemia.
No, I mean that's a minor, but sepsis. So NEC, sepsis. RDS, IVH, and sepsis. So which of any of those do steroids help prevent?
RD respiratory distress syndrome.
Okay. Yeah. Any other ones?
Sepsis.
Oh God, no. Because I mean, the sepsis. If you give them a steroid, they'd be more likely to get septic. In fact, that's one of the risk factors of giving steroids. I mean, so there's a risk factor to everything. Otherwise, we'd give everybody steroids, right? But we don't give steroids after 34 weeks because it can increase the risk of sepsis. So it decreases IVH, NEC, and respiratory stress, but it has the most profound impact on respiratory stress, and the best studied morbidity is respiratory distress. So that's why we give it. Okay. Now, the reason you can't give hydrocortisone is that it doesn't cross the placenta. So don't say you give hydrocortisone. All right, okay. You need to give betamethasone or what?
Dexamethasone.
Dexamethasone, yeah. So those are the 2 steroids you can give. Okay. Let's see. What are the? We already talked about that. Okay. Let's see. What else can we talk about? Oh yeah. So do you give this? So this particular patient, do you tocolyze or no?
Typically, I would tocolyze her, but I'm not sure if she was 30 3 and 6. I did get an MFM consult, but typically I would tocolyze them for 48 hours.
Okay, and what would be the purpose of tocolizing?
It would be to have the maximal effect of the steroids that I'm administering.
Okay. So well, and what are the effects of antibiotics? The antibiotics, I mean, does that decrease RDS? I mean, what do antibiotics do? Why do we even give antibiotics?
To increase the latency.
Okay. All right. So steroids decrease morbidities. Antibiotics increase latency. What does tocolysis do? Is there any other benefit other than latency to tocolizing?
I would also say it would decrease their pain if they're contracting.
Okay. Anything else you want to give?
And you're increasing the risk of preterm delivery.
You're decreasing the risk of preterm delivery? Is that what you're saying?
Yes.
Okay. Is there any role for neuroprotection with magnesium tocolysis? Neuroprotection?
Yes, under 32 weeks gestation.
Okay. Okay. Great. So this patient, you wouldn't give it for that particular indication.
Correct.
Okay. How are you going to counsel this patient as far as subsequent pregnancies and that sort of thing? So she's already delivered. Apparently she had a healthy child at 33 weeks. How are you going to counsel her, like your antenatal counseling for her next, or preconceptual counseling for her next pregnancy?
So she's at increased risk for the actual same event reoccurring. For her case also, I could offer her a course of progesterone. If, just because of her history, she could possibly qualify for a cerclages. It depends upon why she ruptured, if it was preterm labor versus if we assess her cervical length earlier on in her next gestation to see if it will be appropriate for a cerclage placement.
What gestational age would you give a cerclage?
Well, starting at 16 weeks, about 16 weeks, second trimester.
All right, so if they have a normal cervical length at 16 weeks, would you do a prophylactic cerclage?
If they had a history of a preterm delivery that was for cervical incompetence.
Cervical insufficiency, yeah. All right, and so if it was cervical insufficiency, is that typically a third trimester PROM, or is there some other obstetrical outcome that cervical insufficiency would result in?
No, it would be more likely a second trimester loss.
Yeah, usually second trimester loss. Now, for a and it's been a while since I looked at the thing, but for a prophylactic cerclage, now you can put in a cerclage. If they're dilating, if they've got less than 25 millimeters, they have an 8-time increased risk of preterm delivery. So if they're less than 20, if they're not viable, you can put in a rescue cerclage. But for a prophylactic cerclage, what would a patient's obstetrical history have to be to merit a prophylactic cerclage?
Well, she's had a history that was significant for, again, a preterm delivery. And in her cervical length with her subsequent pregnancy, if it was observed to be shortened prior to the cerclage placement, So I would imagine that with a history of preterm delivery, she could qualify for prophylactic cerclage after counseling, and she opts for that.
No, that's not true. So, and don't try to dance around the question. I mean, if I'm asking you a question about a prophylactic cerclage, don't paint a scenario where you're, oh, well, she's got a short cervix, and then maybe, no, I mean, just answer the question. So, so a prophylactic cerclage, and Denise can correct me if I'm wrong, but you need to have 3 prior second trimester losses in order to qualify for a prophylactic, okay, just to put one in. Because there are risks to having a cerclage. I mean, you can cause bleeding, you can cause preterm labor, you can rupture membranes. So if you're just putting in a cerclage with a totally normal cervix that's prophylactic, you have to have a very significant obstetrical history. Now, rescue cerclage is different. If you, and certainly it would be reasonable to monitor cervical lengths, you know, and progesterone and that kind of thing. But and if they have a shortened cervix, then you can talk about doing a cerclage. But typically, cerclages are for the second trimester, less for preterm, you know, PROM and stuff like that. And when you're counseling about their recurrence, they actually tend to recur, and they tend to recur earlier than the current one recurred. So those are things that you'd want to mention. But yeah, no, that's pretty good. Let me see. We have 5 minutes. Let me just look and see if there's anything else I can ask you. Let me see. Tell me about, and this will just be really quick. Tell me about case number 19, the 17010.
Case 17-year-old G1P0 presented for induction labor secondary to 41 weeks, gestational age. No, I'm sorry. She actually presented with signs of complaints of swelling and headache. So she was worked up for a pre-eclamptic workup. Laboratories, labs were drawn on her. She had increased uric acid, and her blood pressures were persistently 150, 140, 150s over 90s to about 100. The decision was for induction of labor. Patient had a favorable cervix. We started her with Pitocin. Patient got to second stage of labor. Patient was without an epidural per her choice. Category 2 tracing was noted when she was actually completely dilated at +3 and pushing. Maternal exhaustion, I didn't want to put on there non-cooperative, but she was definitely exhausted. She was had magnesium sulfate on board. So I assessed her the fetal station, fetal position, and I opt for operative vaginal delivery, and I used the Kiwi vacuum.
Gotcha. Now, what are the indications for doing a vacuum-assisted delivery? What are the indications?
So, arrested or prolonged second stage. Maternal comorbidities that would not allow her to give a good effort with the second stage, with pushing. Fetal compromise as far as category 3 tracing, and you want a more prompt delivery. And again, the station and the position of the fetus.
So I'm sorry, so maternal exhaustion, non-reassuring fetal status, prolonged second stage, anything else? Or arrest, I guess, prolonged second stage, anything else? Is there any other indication? There's one more. So you know what it is?
No, I can't think of it right
Okay,
now.
so maternal cardiac condition that would preclude Valsalva, right? And we can, and so I mean, this vacuum, you want to know the settings. You're going to want to know, there's a, what will qualify as an outlet operative delivery, what would be a low operative delivery. You've got it on your case list, so you want to know about that. We're running out of time, but I would just say, when your exam is, when is your exam?
This week.
Like Thursday or what?
No, it's tomorrow.
Okay. Okay. In the morning or the afternoon?
Morning.
Okay. All right. So the only thing I would do in the next hour is go over your case list. I wouldn't worry about anything else. You know what you know. That's it. The two cases you presented, you started to present it, and then you kind of, oh, wait a minute, no, that's not what happened, and then you went back and changed it. It just doesn't portray a lot of confidence about the thing. So just today, just go over one at a time, just present it once in your mind or speak it out loud, and just kind of get used to orating what you're going to say tomorrow. You don't want to go back and then try to figure out, well, what did I do with this patient? You want to know what's on your list, because that's going to be the thing that's going to help you. So just tonight before you go to bed, just one time go through each of the cases, and then just that's it. Then get a good night's sleep, and you'll do fine.
All right, thank you.
All right, good luck.
Okay, thank you, Dr. Farnham, for being our guest faculty tonight, and Dr. Hood, just do exactly what Dr. Farnham said. Just review your cases before you go to bed, and you know what you know, and go in there and give them every reason not to fail you. Make sure you just regurgitate everything you know about your cases. All they want to know is make sure that you practice safe medicine, that you take good care of patients, and you practice the standard of care. And if you think of it that way, you should do fine on your exam. Okay, this is Dr. McSherry concluding tonight's webinar. It's 10:01 p.m. on December 2nd, 2013. Tomorrow night we'll be working with Dr. Walton. She's guest faculty with Dr. Dunham and Dr. Kong. Tomorrow night's case of the day, if you're listening, is going to be on twins. I'll give you a hint. And we'll be doing Dr. Dunham's case list tomorrow night. So take care, have a good night, and we'll see everybody tomorrow. Thank you for being